Let's turn our discussion now to optimizing chemotherapy in advanced non-small cell lung cancer. We do the molecular testing more times than not. We're not going to find an oncogenic driver. We're going to be talking about the issues for first-line chemotherapy uses. So Tom, why don't you kind of walk us through your thought process in that patient?
I think there's initial disappointment when you don't find the oncogenic driver mutation.
On the doctor or the patient?
Both. I think that's something that's changed over the last 5 or 10 years. And I think chemotherapy still is a major contributor to the care of lung cancer patients. In terms of even the people with targeted lesions will get chemotherapy at some point. And many of the people, like you said, are mutation negative, start with chemotherapy. And when I kind of see a lung cancer patient with advanced disease, I look at their performance status, their comorbidities, and then after that, I think I talk to them pretty extensively about their preferences and what their goals of the care are. I sort of divide the patients to performance status. 0 to 1 patients will either get carboplatin, pemetrexed, carboplatin, paclitaxel, and bevacizumab. Are my two most commonly used therapies. I think you can make a justification for carboplatin, pemetrexed, and bevacizumab, but I just tend to use that third one a little bit less frequently.
And what are your choices in the squamous population of patients?
For the squamous patients, I generally will treat with carboplatin, gemcitabine, carboplatin, paclitaxel, and carboplatin, nab-paclitaxel is an option as well.
So in your choices, at least for the non-squamous, you mentioned bevacizumab. How often is that used in your practice? What are the issues there with recommending it?
So I think it's a minority of patients. I'd say maybe 1 in 5 or so get it approximately. I think some of the issues are the uncontrolled hypertension, the hemoptysis, and some other contraindications. I have a little bit of hesitancy of using it in people over 70, and I think you have to sort of triage those patients very carefully. And I think the thing that sort of changed my practice prescribing is that I think the carboplatin pemetrexed is very easy to give, and I think patients don't have to worry about the hypertension or the hemoptysis, and I think that sometimes sways me a little bit more towards the platinum pemetrexed in some patients.
Yeah, I mean, I think that this is a curious area in oncology for me personally, because we've kind of slipped into those 2 drugs, carbo-pem, are as good as those 3 drugs, carbopaclitaxel, bevacizumab. And we did a recent survey, I forget where this was, of so-called thought leaders. And all of them said that if you did a trial, carbo-pem plus or minus bev, they were convinced that it would show a survival advantage.
Which is quite interesting because we've had bevacizumab in addition to cisplatin gemcitabine, a la the AVAIL study, which did not show a benefit in survival.
Which was a secondary endpoint.
Yes.
That was a positive trial, Dr. Levy.
Okay.
It was a PFS endpoint. So.
But there are trials that sort of the pronounced trial that compared carboplatin PEM to carboplatin paclitaxel bevacizumab, with admittedly a atypical endpoint, we'll call it, of PFS and grade 4 toxicity, but the outcomes were relatively similar.
But it was woefully underpowered to assess outcomes. So I think I don't think physicians should be drawing the conclusion that those 2 drugs are as good as those 3 drugs in this setting. Although I do think in common practice, we're very dominated by pathways at UPMC, and we're spot on. 21% of our first-line patients get bevacizumab. Is that similar to others' practice?
Yeah, I think it dramatically varies from doctor to doctor is my experience, and but I think the average at our place would be around 20% as well.
Okay.
Less controversial, though, is the difference in toxicity profiles.
Right.
And I see this a little bit from a practical perspective as a case of pay me now or pay me later.
Right.
With PEM-carbo, you have a less toxic regimen in the induction period, your initial 4 to 6 cycles, but you have to continue a cytotoxic in your maintenance. Whereas I think paclitaxel is a little more challenging than pemetrexed in that induction setting, but then you're not using a cytotoxic in your maintenance setting.
I couldn't agree more. I think often patients' preferences are driven by the side effect profile. And alopecia is a big one with many people that they don't want to do that. Ben, I'm going to ask you, so we've established that in the first line and the second line, that cytotoxic chemotherapy has a role. We've certainly seen things change with immunotherapy, but just talk us through the getting from first line to second line to third line. I mean, historically, there's been a huge drop-off on each line. And
Yeah,
Thoughts?
so I think that for most of my patients, and we didn't talk about this in the first line, that we are offering these patients who tolerate treatment and who are at least achieving stable disease after 4 cycles maintenance chemotherapy, and that affords us the ability to follow these patients every 3 weeks and give an active drug. Most common in my practice has been pemetrexed. Second line options, you do have a drop off, and I would say that the same formulas that go into deciding on first line regimens that Tom alluded to, including performance status and patient preferences and comorbidity, should also go into decisions regarding second line. I think second line, we try to put every patient who reaches second line or who has progressed on platinum chemotherapy a clinical trial. I think there's an urgent need to have more clinical trials in the second line and third line space. But outside of a clinical trial, there are competing options. I think certainly checkpoint inhibitors with nivolumab being the leader there are very reasonable for both squamous and the non-squamous patient population, irrespective of PD-L1 status of their tumor. So I think that my default second line has been nivolumab. It's well tolerated, again, outside of a clinical trial. Other options include docetaxel or docetaxel plus ramucirumab for very fit patients. So I think, and then we move to third line. We have very few approved drugs in third line, and it really gets to be a dicey situation on what patients are going to get third line. And I think second line decisions often impact on third line decisions. So when patients are getting a checkpoint inhibitor and they're doing very well in the second line and they don't want to go back to chemotherapy, it makes third line decisions, if they progress and when they progress, more challenging and what to do there.
Yeah, I've always felt that part of that drop-off was the two things: the fear of toxicity of docetaxel, because that was your choice, and the less than stellar benefit that you would get with docetaxel. You think that'll change with the immunotherapies? More patients will be getting more lines of therapy because now we have immunotherapy as a second line treatment. It's pretty well tolerated.
I think so. I think patients may be a little more enthusiastic to go on clinical trials third line or receive drugs if they've gotten reasonable benefit from first line and second line and tolerated it okay. I think they may be less reluctant to see a third line agent, especially if it's not chemotherapy. But even if it is chemotherapy, I think there's a little more buy-in from the patient to go on to further therapy.